it gives me great pleasure to introduce our speaker today. Dr. William Abraham is going to be giving us a talk today from Ohio State University. He did his medical school training at Harvard University and then went on to residency in internal medicine and fellowships in cardiovascular disease and advanced heart failure transplant at University of Colorado Health Sciences Center. He currently is at, as I mentioned, Ohio State University, where he holds several leadership positions, including Associate Dean, Division Director, and Manager of the College of Medicine's non-cancer clinical and translational research portfolios. He's well published with over 1,000 original papers, abstracts, book chapters, and review articles in high-impact journals. His main research work has been in three main areas. One, which we're going to hear about today, device development and heart failure, but also in neurohormonal therapies and heart failure, and acute heart failure and renal dysfunction impacting or complicating heart failure. As I mentioned today, he's going to be discussing device-based therapies for improving the care of our heart failure patients. And I think if Sean has the slides ready, then I'll let Dr. Abraham go ahead and get started.
Thank you so much. So let's go ahead forward to the second slide, and it simply lists my disclosures in regard to this presentation. I received personal fees from Impulse Dynamics and V-Wave Medical over the last 12 months, and I will talk a bit about devices from those companies. The other devices that I'll address, I haven't received any consulting or other personal fees from those companies for a very long time. So let's go to the next slide. And first of all, cover why this is important. And I think you all already know the information that's shown on this slide, so I won't take you through all of it in great detail. There are just a couple of key points that I want to emphasize. While we've been focused for the last 18 months on a devastating global pandemic, that is the COVID-19 pandemic, I think it's worth noting that heart failure is also of global pandemic proportions, affecting at least 60 million people worldwide. And the other statistics shown on this slide come from the AHA Heart and Stroke Annual Statistical Update and give you figures for the US. But I want to emphasize that heart failure results in substantial morbidity and mortality, but it also results in substantial disability affecting our patients' quality of life and functional status and exercisability as well. And as I'll emphasize in a moment, really improving all of these patient-centered as well as clinical outcomes are important in the treatment of heart failure patients. That's emphasized a bit more on the next slide, which shows you or summarizes the substantial reduction in quality of life and the high symptom burden associated with heart failure on a daily basis. And again, for time's sake, I won't take you through all of the statistics that are highlighted or reviewed on this slide. Suffice it to say that heart failure has a substantial impact on physical, social, and emotional functioning. If you focus on the center of the slide, you'll see that about 3/4 of our heart failure patients find it difficult to carry out usual daily activities, so that improving heart failure symptoms, quality of life, and physical activity continues to be an unmet medical need in patients with heart failure. On the next slide, I'll present to you what I would consider to be our goals of heart failure treatment. And really the overriding goal here is to slow disease progression to improve symptoms and clinical outcomes. You'll see that the goal isn't to cure heart failure, although we'd love to be able to cure heart failure, but heart failure is a chronic progressive disease syndrome. And as of yet, no cure for heart failure really exists. There's no quick fix, such as in aortic valve replacement for aortic stenosis. So our goals really include improving functional capacity, improving symptoms and health status. reducing heart failure-related hospitalizations, avoiding the need for LVAD or transplantation, and improving survival. And this can be done today with a variety of approaches. Foundational heart failure drug and device therapies have been shown to improve symptoms and or clinical outcomes. And these include all of those therapies, particularly for HFrEF, that you already know about: renin-angiotensin system inhibitors and antagonists, beta blockers, MRAs, and most recently the addition of SGLT2 inhibitors to our armamentarium, as well as electrophysiological devices, ICDs, and cardiac resynchronization therapy, which are all guideline recommended medical and device therapies for the treatment of heart failure. However, despite these therapies, and also in the HFpEF population, heart failure symptom burden remains high and outcomes remain poor. So there is an ongoing and critical need for the development of newer approaches to add incremental value to the treatment of heart failure patients across the spectrum of LV ejection fraction. So let's go to the next slide, where I simply make the point that drug and device therapies for heart failure are really complementary. These aren't competing approaches, they are complementary approaches. And in fact, we've seen in many clinical studies the synergistic, or in some cases additive, effects of drug and device therapies in improving both clinical and patient-centered outcomes in heart failure patients. Drug therapies remain foundational, and they have been demonstrated primarily to improve clinical outcomes. In many of our drug therapy trials, while we've demonstrated substantial improvements in morbidity and mortality, particularly reductions in mortality and in heart failure hospitalizations, we haven't necessarily demonstrated a large impact on patient-centered endpoints such as quality of life. For example, the most recent drug therapies to enter our armamentarium for the treatment of heart failure, the SGLT2 inhibitors, significantly reduce mortality and the risk for heart failure hospitalization, but they variably improve quality of life. And when they have been demonstrated to produce a statistically significant improvement in quality of life, the average between group improvement in the KCCQ, quality of life score, has only been about 2 or 3 points, a value which is below the threshold considered to be clinically meaningful, that threshold being a 5-point or greater improvement in the KCC quality of life score. So most of our drug therapies have significant effects on clinical outcomes and variable and at times small effects on patient-centered endpoints. Device therapies, on the other hand, have been shown to have greater effects on improving symptoms compared to drug therapies. If you look at cardiac resynchronization therapy as an example, the average improvement in quality of life score is about 8 to 10 points, about 3 times that seen with drug therapies for the treatment of heart failure. And as I mentioned earlier, improving both clinical and patient-centered outcomes is important and often requires the use of both heart failure drugs and devices. And of course, the concomitant use of drug therapies along with CRT is well established, has been well established over the past 20 years. So what I want to do over the course of the remainder of this talk is introduce to you some more recent or recently approved novel heart failure devices from the past few years. I've listed them here along with their FDA approval dates. The CardioMEMS heart failure system, an implantable hemodynamic monitoring system, the Remedy system, the MitraClip, the Optimizer Smart system, the Veristim Neo system, and there are many, many more to come which are still investigational. I'm going to focus on the 4 that are highlighted on the next slide. And will not discuss the Remedy system because it treats a comorbidity of heart failure, namely central sleep apnea, but not heart failure per se. And I won't delve into all of what's going on in investigational devices for heart failure, but I will highlight one near the end of this discussion. So let's go forward, and we'll first talk about pulmonary artery pressure-guided heart failure therapy. The system, which is FDA approved for this, is shown on this slide. It involves the implantation into a pulmonary artery of a MEMS-based pressure system sensor, which is wireless, which is batteryless, which can be interrogated using a simple home electronic system. And it provides the type of information shown on the bottom right-hand side of this slide. Now, this has been around for a few years, FDA approved for a few years, and I suspect you have experience with it and you know it well, and its sort of method of use is shown in the example in the lower or on the lower right-hand figure of this slide, panel of the slide, where you will see that at the time of implantation of the device, the pulmonary artery pressures were elevated. The patient was treated with intensified diuretic therapy to lower those pressures into a target or normal range, and then to keep them there in follow-up. And what we've demonstrated in clinical trials that I'll share with you in a moment is that when you do this, when you use pulmonary artery pressure guided heart failure care to lower and keep PA pressures within a target range, you can substantially reduce the risk of heart failure hospitalizations. We first showed that in the Champion trial, a prospective multi-center randomized controlled single-blinded clinical trial. And it's important to note that in this study, patients were enrolled regardless of their LV ejection fraction. So this study included not only HFrEF, but also HFpEF patients, and the primary endpoint was recurrent or cumulative heart failure hospitalizations. On the next slide, you'll see the primary results of this study. First of all, the trial met its, go forward one more slide. The trial met its primary endpoint of reducing heart failure hospitalizations. Cumulative heart failure hospitalizations reduced by 33%. This is a relative risk reduction over a year's time, as well as a reduction in the combined endpoint of death or heart failure hospitalizations. And click forward one click, and then you'll see also the trial demonstrated significant reductions in all-cause hospitalizations, as well as all-cause death or all-cause hospitalizations. Now, going forward to the next slide, you'll see that these effects were demonstrated regardless of LV ejection fraction. There was a pre-specified subgroup analysis based on LV ejection fraction. And in short, what that demonstrated was that pulmonary artery pressure guided heart failure care resulted in significant reductions in heart failure hospitalizations in patients with HFrEF, in patients with LVFs of 40% or greater, and in patients with ejection fractions of 50% or greater. So this particular approach to heart failure treatment is indicated for the management of class 3 heart failure patients, regardless of their LV ejection fraction. There is, as shown on the next slide, additional supportive data. This data comes from the CardioMEMS post-approval study, actually published last year, or maybe earlier this year. The reference is to the ACC presentation, but it's now published. 1,200 patients looking at the year pre-implant versus the year post-implant, and demonstrating marked reductions in the rate of heart failure hospitalization, as well as the combined risk of heart failure hospitalization and mortality. Going forward, additional data, what I'll call real-world data from Haywood, has demonstrated in a population of patients similar to that enrolled, perhaps a bit older and a bit sicker than that enrolled in the Champion trial, demonstrated on the next slide high patient adherence to taking their daily pressure measurements, and on the following slide, high clinician compliance to using that information to lower pulmonary artery pressures. If you look at this slide, you'll see the control arm from Champion in red, the treatment arm of Champion in black, and the real world experience, 2,000 patients in blue. And you'll see that if anything, clinicians in the real world setting did even a better job than we did in the Champion randomized controlled trial in lowering pulmonary artery pressures with the use of PA pressure-guided heart failure therapy. Now, what does this result in? In a separate study from Desai and colleagues, using the administrative claims data from the CMS standard analytical file, you will see that on the next slide, over a follow-up period of 6 months, again, looking pre-post, go ahead, forward one slide, there was demonstrated a 45% relative risk reduction in recurrent or cumulative heart failure hospitalizations. So the data appear to be quite strong, supporting the use of PAP-guided heart failure management in class 3 heart failure patients, and ongoing trials are looking to expand this indication into patients who are less sick with class 2 heart failure. So let's move on now to the next slide with functional mitral regurgitation and reduction of mitral regurgitation as a target for heart failure therapy. Why is this important? Well, about 40% of our heart failure patients have moderate or severe secondary or functional MR. This functional MR is associated with a poor prognosis in heart failure patients. FMR contributes to heart failure disease progression, symptoms, and poor clinical outcomes via increased ventricular loading and increased left atrial pressure, as shown on the simple view of its pathophysiology at the bottom of the slide. And thus, functional MR has become a target for heart failure therapy. Previously, there had been no trial of surgical reduction of FMR that provided definitive evidence that reducing MR in these patients improves clinical outcomes. No prior randomized control of surgical MR reduction had been performed. But with the advent of transvascular approaches to MR reduction, we were able to do a randomized controlled trial called the COAPT trial. I'll show you the results for that on the next few slides, of this transvascular edge-to-edge mitral valve repair approach in patients with moderately severe or severe secondary MR associated with heart failure. So the trial was called the COAPT trial. It was published online September 23rd, 2018 in the New England Journal of Medicine, presented at that time at the TCT meeting, and it met its primary endpoint, demonstrating a marked reduction in cumulative or recurrent heart failure hospitalizations over a 24-month period of follow-up, as shown on this slide. Relative risk reduction, 47% for recurrent heart failure hospitalizations. Primary endpoint, there were 10 pre-specified secondary endpoints, powered secondary endpoints in this trial, and all of them were met. Again, for time's sake, I won't take you through all of them, but suffice it to say that we evaluated endpoints that looked at reduction in MR and other important echocardiographic parameters, and then important both patient-centered as well as clinical outcomes, including all-cause mortality at 24 months. All of these significantly improved. So based on the data from the COAPT trial on March 14, 2019, the FDA expanded the indication for the MitraClip device to include patients with normal mitral valves. This is secondary, not primary valve disease. Patients with normal mitral valves who develop heart failure symptoms and moderate to severe or severe mitral regurgitation because of diminished left heart function, commonly known as secondary or functional MR, despite being treated with optimal medical therapy. So if you have these patients with heart failure and 3+ to 4+ MR, they should undergo an evaluation, and if they meet the COAPT profile of patient inclusion, they should be considered candidates for transvascular edge-to-edge mitral mitral valve repair, according to this FDA indication. Now, the next device that I'll review with you is a device that delivers a therapy called, yes, go ahead, one more, please, cardiac contractility modulation therapy. I think for many, this has been felt to be sort of a black box. How does this work? It is a device-based therapy that delivers an electrical impulse to the heart during the absolute refractory phase of the cardiac cycle. So unlike cardiac pacing, it's not intended to capture or pace the heart. It won't do that during the absolute refractory period. So what do these electrical signals do? Well, these electrical signals affect the biology of the failing myocardium, specifically genes, proteins, and phosphorylation in a way that improves function. It increases cardiac contractility with no increase in myocardial oxygen consumption. So the efficiency of the heart is improved. And these biological effects are seen early in the area of signal application, later in more distant regions of the left ventricle. These signals have been shown to improve not only cardiac structure and function, but also quality of life and other important patient-centered endpoints. It's not been yet evaluated in a clinical outcomes trial looking at mortality and heart failure hospitalization. So here's the trial that led to FDA regulatory approval, a trial called the FIX-HF5C study, published in JACC Heart Failure in 2018, simultaneously presented at the HRS annual scientific meeting. The primary endpoint was improvement in peak VO2, an important measure of exercise capacity and prognosis in heart failure patients. And the trial demonstrated a nearly 1 ml per kilogram per minute improvement in peak VO2, a value shown here on the slide that is comparable to the improvement in peak VO2 seen with cardiac resynchronization therapy in patients with a wide QRS complex. This device has been developed for and studied most in patients with narrow QRS complexes not indicated for CRT. If you go to the next slide, you'll see that the therapy also has a significant effect on improving quality of life. Here, the quality of life instrument used is the Minnesota Living with Heart Failure questionnaire. Here, a lower number is a better number and improved quality of life. And you'll see that there was an 11-point between group improvement in the QOL score in the patients treated with cardiac contractility and modulation. There was also, as shown on the right-hand panel of this slide, a significantly higher response rate, proportion or percent of patients who improved their New York Heart Association functional class ranking by at least one class if randomized to the CCM or treatment group. On the next slide, you will see that these effects were seen regardless of LV ejection fraction over the range of 25 to 45%. So I should have emphasized that early on, that this therapy has been most well studied in patients with mild to moderate reductions in LV ejection fraction, and not in patients with severely reduced EFs below 25%, or those with normal EFs above 45%. But you'll see that on this slide, there were significant clinical benefits in both HFrEF and what we call this HFmrEF group, patients with mildly reduced ejection fractions, who currently have no device therapies at their disposal, with the exception of CardioMEMS. So based on this data, on March 21st, 2019, the FDA approved the Optimizer Smart system for the delivery of cardiac contractility modulation, specifically for those studied in the FIX-HF5C trial. New York Heart Association Class 3 patients who remain symptomatic despite guideline-directed medical therapy, who are normal sinus rhythm, not indicated for CRT, and have an LVEF ranging from 25 to 45%. I'm sorry, so it should have asked you to advance the slide where you will see that, that indication statement. So let's go on to the next and sort of last of these recently approved devices, and then I'll go over one investigational therapy with you. The therapy here is called baroreflex activation therapy or barostimulation. And the way that this works is that a neurostimulation device is implanted with a unilateral lead placed over the carotid sinus. It gives an electrical signal to the carotid sinus, which creates an afferent signal to the brain, mimicking mechanical loading of the carotid sinus, the high pressure baroreceptor in the carotid sinus, in a way that results in rebalancing of the autonomic nervous system in heart failure patients. As you know, in heart failure, the sympathetic nervous system is activated, the parasympathetic nervous system is inhibited. And so with barostimulation, the opposite occurs. You get an integrated autonomic nervous system response inhibiting sympathetic activity, enhancing parasympathetic activity, and this has favorable effects on the heart, the vasculature, and the kidneys in a way that may ultimately improve clinical outcomes, but to date has been shown to improve patient-centered endpoints, again, such as exercise capacity and quality of life. So there have been 3 significant clinical studies done of barostimulation in heart failure over the past decade or so. A phase 1 study for proof of concept in a small number of patients, and actually fairly substantial phase 2 trial, a randomized controlled phase 2 study in 146 patients, and then a pivotal trial that led to regulatory approval called the BEAT-HF trial in 408 patients. The next slide will show you the design of the BEAT-HF trial. This was the very first study initiated under the FDA's Expedited Access Program, or what is now referred to as the Breakthrough Devices designation. And it's a 2-phase study with an expedited phase and an extended phase. The expedited phase is intended to evaluate safety as well as morbidity and mortality trending. And the primary endpoints for effectiveness are really patient-centered endpoints, including quality of life score and 6-minute hall walk distance, supported by a biomarker, NT-proBNP. And then in phase 2, or the extended phase, which is now ongoing, still ongoing, for morbidity and mortality, and the totality of evidence will be presented in the post-approval, post-marketing setting. So if you go to the next slide, you'll see the top-line results of the expedited phase of the BEAT-HF trial, demonstrating marked improvements in exercise capacity, a between-group improvement in 6-minute hall walk of about 60 meters or 20%, which would be considered to be highly clinically meaningful, a between-group improvement in quality of life score of 14 points, which is on par with other device therapies such as CRT and MitraClip and others in heart failure, and way exceeds what we've seen with drug therapies for the treatment of heart failure, and about a 25% between-group improvement in NT-proBNP. And if you look at the predictive value of this fall in BNP from, for example, or as observed, for example, in the Paradigm-HF trial, this would be predictive of a reduction in mortality and heart failure hospitalization. Of course, we need to wait until the final phase of this trial is performed to see whether or not barostimulation does in fact improve clinical outcomes. But in the meantime, the FDA has approved the Barostim Neo system for the delivery of baroreflex activation therapy to improve patient symptoms. And specifically, it's approved for patients who remain symptomatic, despite treatment with guideline-directed medical therapy, are in neurocardioization class 3 or class 2, having recently been in class 3, who have an LV ejection fraction of 35% or less, an NT-proBNP level less than 1,600 at baseline, and excludes patients who have an indication for cardiac resynchronization therapy. Now, finally, I just want to leave you with a brief view of what's on the horizon. This slide presents a partial list of investigational devices for the management of heart failure. It's a very exciting era in device development for heart failure. Interatrial shunts, cardiopulmonary nerve stimulation for the treatment of acutely decompensated heart failure, newer temporary and permanently implanted mechanical circulatory support devices, next generation implantable hemodynamic monitors that can provide a direct measurement of left atrial pressure, various other neurostimulation devices, and the list goes on and on. I'm going to just summarize briefly interatrial shunt devices because they represent perhaps one of the more mature investigational devices for heart failure. There are now 2 ongoing pivotal trials which will conclude in the next couple of years. And this slide shows the mechanism of interatrial shunting in heart failure. How does it work? So essentially, a device is placed in the interatrial septum, creating a very small opening, very small shunt between the left atrium and right atrium. The average shunt ratio is about 1.2 to 1. Much less than what is considered concerning in the setting of a naturally occurring ASD. We don't close ASDs until they've got a shunt ratio of 1.5 to 2 or greater. This would be a small enough hole that if it were naturally occurring, it would have no untoward consequences for a person or a patient. So essentially, this small shunt shunts excess LA volume to the right atrium. This results in a lowering of left atrial pressure. The whole mechanism of action here is based on pressure gradient. It represents an on-demand and auto-regulating left atrial pressure lowering system. As left atrial pressure goes up, the gradient between the LA and the RA increases, the amount of volume goes up, and the left atrial pressure is lowered. And importantly, it's necessary to understand that left atrial pressure lowering predominates over right atrial volume increase, so that pulmonary artery pressure remains unchanged or is lowered, and right heart function is preserved. And this has been demonstrated both in preclinical animal studies as well as in human pilot studies, which are referenced on the slide. And the net effect to date, and you can't take this to the bank yet because these are all from feasibility and pilot studies, the pivotal trials are now ongoing, is a reduction in pulmonary congestion and heart failure events, improve functional status and symptoms, and reverse LV remodeling. So how does a small interatrial shunt reduce LAP in both HFrEF and in HFpEF? Well, it relates to the steepness of the LV pressure volume curve in both HFpEF and in HFrEF patients. And here you can see in curves, I borrowed this from a publication from Dan Burkhoff, but I've superimposed these green arrows. You can see that a little bit of volume reduction. And if you look at the absolute volume change relative to the starting volume, you will see that on a percent basis, this is a very small reduction in volume, results in a very large reduction in LV pressure because of the exponential nature of this LV pressure volume curve in heart failure patients. So let's go to the next slide, and it simply lists several lines of evidence supporting interatrial shunt therapy as a treatment for chronic heart failure. Old observations that patients with mitral valve stenosis and an atrial septal defect have fewer symptoms than patients with an intact septum, and closure of ASDs in patients with unrecognized LV dysfunction often results in elevated left atrial pressure and acute pulmonary edema. But more importantly, there are now a number of very good, rigorous preclinical animal studies that demonstrate hemodynamic, echocardiographic, and survival benefits with interatrial shunting, and first-in-human and clinical pilot studies, which support the safety, feasibility, and potential effectiveness. I want to underscore the term potential here. This remains to be proven definitively in those ongoing pivotal trials of interatrial shunting in heart failure. So if you go to the next slide, I just summarize what we currently know about interatrial shunting from completed interatrial shunt feasibility trials. They've demonstrated striking consistency across multiple devices. There are now no less than 7 approaches to interatrial shunting that are currently under clinical investigation. 2 of them progressed so far to pivotal trials. And the results have been very consistent, demonstrating high rates of implant success, excellent procedural and device safety, improvements in New York Heart Association functional class ranking, quality of life score, and 6-minute hall walk distance, and low rates of mortality and heart failure hospitalizations, suggesting that there might be a favorable impact on clinical outcomes. But of course, we're waiting for the results of the pivotal trials. Now, one of the 2 ongoing pivotal trials is called the RELIEVE-HF study in both HFrEF and HFpEF patients. And it's got an interesting trial design as shown here because there are 2 cohorts and 3 arms. There is a randomized double-blind cohort, but there's also a parallel rolling cohort. And the parallel rolling cohort allows us to look at data to assess important things such as shunt patency, as well as look at preliminary effectiveness signals as the trial goes along. So the rolling cohort recently closed. The most recent cut of that data was presented in June at the European Society of Cardiology Heart Failure meeting. And I'd like to share a little bit of that with you. Let's go to the next slide and click forward one more click. You'll see the patient characteristics here. And, by luck, we've enrolled about, half the patients are HFrEF and half are HFpEF. And that allows us to do some subgroup analyses here as well. But you'll see that in general, this is an elderly group of sick heart failure patients with lots of comorbidities. They have low GFRs, poor hemodynamics, poor quality of life, 6-minute hall walk distances. And look at the NT-proBNP levels at baseline. The average NT-proBNP level is quite high, consistent with an at-risk heart failure population. Now, if you go forward to the next slide, you'll see our experience to date in terms of procedure success and safety, demonstrating a very high procedure success, 99%, and excellent safety. For time's sake, I'll highlight that we have seen no major adverse cardiac or neurological events at 30 days, no device or procedure-related MACNE at any time, 100% shunt patency through at least 12 months, and this is with 15 months of median follow-up, and the implant procedure is relatively short. Most of the average of or median of 74 minutes is spent on doing all of the protocol mandated procedures such as assessment of hemodynamics and invasive echocardiography to guide the transeptal procedure. And if you go forward a slide, you'll look at the impact of interatrial shunting on quality of life. KCCQ overall scores, absolute value shown on the left, responder analysis shown on the right. You'll see that there's an early and sustained about 12 to 15 point improvement in the KCCQ overall score with interatrial shunting. About 70 to 75% of patients experience a clinically meaningful, that is at least a 5-point improvement in the quality of life score. Going forward to the next slide, you'll see that these improvements occur regardless of LV ejection fraction. Both HFpEF, shown on the left, and HFrEF patients, shown on the right, respond to interatrial shunting. So to summarize what I've said, and I'm afraid I've probably said a lot in the past hour, drug therapies, I'm sorry, go ahead to the last slide, please. Drug therapies remain the foundation of heart failure management and improve clinical outcomes. Implantable hemodynamic monitors and several recently approved novel interventional devices improve symptoms and/or outcomes. The latter in the case of MitraClip in heart failure patients who remain symptomatic despite treatment with guideline-directed medical therapies. Many novel devices for heart failure are now under investigation, and among these, interatrial shunting seems to be particularly promising for the treatment of heart failure regardless of LV ejection fraction. And with that, I'd be pleased to have the slides down and be happy to take any questions that you have. So thank you so much for your attention.